welcome back to the Deep Dive. Today we are opening up a file that affects millions of people, yet is, well, it's misunderstood by almost everyone who has it.
That's so true.
We're tackling a topic that sounds like it belongs strictly in a medical textbook, but in reality, it is probably the #1 conversation starter at doctors' offices around the world. We are talking about dyslipidemia.
It sounds a bit intimidating, doesn't it? Dyslipidemia. But if you have ever sat on that crinkly paper in a doctor's office and heard the phrase high cholesterol or...
You need to watch your numbers.
Exactly. Then you are actually talking about dyslipidemia.
Right. And usually the conversation just stops there.
Yeah.
You get a lecture about bacon, maybe a prescription, and you go home. But looking at the research we have today, specifically this comprehensive medical chapter on cardiovascular disorders, it turns out dyslipidemia is a lot more complex than just having too much fat in your blood.
Oh, absolutely. It isn't just grease in the pipes. Not at all.
So what is it then?
It is actually a sophisticated, intricate imbalance of the body's entire transport system.
Exactly. And the reason we are doing a deep dive on this is because understanding that imbalance is, well, arguably one of the most important things you can do for your long-term health.
It really is. The source material we have today is fascinating because it frames this condition with a very specific and I'd say somewhat chilling word.
Which is?
Silent.
That was the hook for me.
Yeah.
That idea that you can be walking around feeling perfectly fine, no pain, no dizziness, nothing, while this massive physiological drama is unfolding inside your arteries.
That is the danger. For the vast majority of patients, dyslipidemia is asymptomatic for years, maybe even decades. You don't feel your arteries hardening. You don't feel the plaque building up. The first symptom isn't a warning light or a fever. It is the crash.
Wow.
It is a catastrophic event like a myocardial infarction, a massive heart attack, or a stroke.
Which is just terrifying.
No.
So our mission today is to make the invisible visible. We want to decode this silent system. We are going to break down how the body transports energy and repairs itself using these fats, how that system goes haywire to create a clog, and then look at the toolbox we have to fix it.
And it's a huge toolbox. The sources lay out everything from, a simple bowl of oatmeal all the way to heavy-duty pharmaceuticals that literally hijack your liver's chemistry.
It's an amazing spectrum. But before we can talk about how to fix the machine, we need to understand the parts, right?
We have to. We need to start by clarifying what we are actually talking about when we say cholesterol, because in the medical world, it is not just one thing.
Right. When you get a blood test, you see a bunch of acronyms. Let's break the key players down. First up, LDL.
Low-density lipoprotein. In the context of our source material, this is usually the primary target. We often call it the bad cholesterol.
Okay, the bad one. Why?
Because elevated levels are directly linked to the development of coronary heart disease. Think of LDL as the delivery truck bringing fat out to the body.
I like that.
But if you have too many trucks on the road, traffic jams happen.
And there is HDL.
High-density lipoprotein. So if LDL is the delivery truck, HDL is the good cholesterol. It's basically the cleanup crew.
The cleanup crew.
Or the recycling truck, you could say. It scavenges excess cholesterol from the tissues and takes it back to the liver to be disposed of.
So high HDL is good.
Yes, but here is the nuance the source really emphasizes. It is not just that high levels are great. It is that low levels are actually considered an independent risk factor.
Oh, okay. So you can have normal bad cholesterol, but if your good cholesterol is too low, if your cleanup crew is understaffed, you are still at risk.
Precisely. You need that balance. If you aren't clearing the streets, debris accumulates, even if the delivery trucks aren't speeding.
Got it. Then we have triglycerides,
which are a different form of fat entirely. While cholesterol is used for building things like cell walls and hormones, triglycerides are used for energy storage.
So they're the fuel.
They're the fuel in your tank. But high levels there are also problematic, which we will definitely get into.
And finally, total cholesterol, which I assume is just everything added up.
Roughly, yes. It is the aggregate measure. But the goal here isn't just to look at a spreadsheet of numbers and say lower is better. Dyslipidemia is a physiological dysfunction. It means the transport system is broken.
I love that analogy of a transport system.
Yeah.
Because I think people imagine cholesterol as just sludge floating in a pipe.
Right, which it's not.
But the text explains that these fats, cholesterol and triglycerides, they don't just float freely in the blood, do they?
No, and that is a fundamental chemistry problem the body has to solve. Blood is mostly water. Lipids, like cholesterol, are fats.
And oil and water don't mix.
They don't mix. If you just dumped pure cholesterol into your bloodstream, it would clump up into globules and, well, probably kill you instantly.
Okay, so how does the body move it?
It wraps them in proteins.
Like a package.
Exactly. The
Okay.
fat is the cargo and the protein is the vehicle. That package, the fat plus the protein wrapper, is what we call a lipoprotein. That is what LDL and HDL actually are.
They're submarines carrying cargo.
Perfect analogy. They're submarines carrying a cargo of fat through the watery bloodstream.
Okay, so let's talk about the crash. The source material goes into really graphic detail about the physiology of the clog, or pathophysiology. How does atherosclerosis, hardening of the arteries, how did that actually start?
Right.
Because it's not just grease sticking to the wall like bacon fat in a drain.
No, it is much more active and, frankly, sinister than that. It is almost like a crime scene, a slow-motion invasion. It starts with something called LDL retention.
LDL retention.
So imagine the LDL submarine is cruising through the artery for various reasons, maybe high blood pressure, maybe smoking. The lining of the artery, the endothelial layer, becomes a bit permeable. The LDL crosses that barrier.
It slips through the cracks.
It slips through the cracks and gets into what's called the subendothelial space.
So it trespasses. It's not blocking the pipe yet. It's buried in the drywall of the pipe.
Exactly. It is trapped inside the wall, and once it is trapped, it gets chemically modified. The text mentions it gets oxidized or glycated.
Like it starts to rust.
Think of it like a car rusting or rotting. This oxidized LDL is toxic. It's not supposed to be there, and the body knows it.
So the body sends in the police.
It does. This mildly oxidized LDL acts like a distress beacon. It signals the immune system. Specifically, it recruits monocytes, a type of white blood cell, to come and investigate.
And these monocytes,
They enter the artery wall and transform into macrophages.
macrophages are the eaters of the immune system, right? Like Pac-Man.
Yes. They are there to clean up the mess. They start eating the oxidized LDL. But here is where it goes wrong, and this is the tragic irony of heart disease.
What happens?
They eat too much, they accelerate the oxidation and literally stuff themselves with fat until they become completely dysfunctional. Pathologists call them foam cells.
Foam cells. That sounds deceptively soft.
It isn't soft, it is the beginning of the plaque. These foam cells die and release inflammatory signals, cytokines, that call in even more cells. It creates a vicious cycle of inflammation.
So atherosclerosis isn't just a passive buildup of grease?
No, it is an active inflammatory disease caused by the body trying to clean up trapped LDL.
And over time, this creates a plaque.
Right. Repeated injury and repair create a fibrous cap. It is like a scar covering a core of lipids, dead cells, calcium, and collagen.
And the source says the danger zone isn't necessarily just having the plaque. It is what happens to that cap.
This is the critical insight. You can have a large plaque that is stable, but if that fibrous cap is thin or unstable, it can rupture, it can burst.
And when it bursts,
the contents spill out into the bloodstream and the body instantly tries to clot it. That clot coronary thrombosis blocks the artery, and that is your heart attack, your stroke, or sudden death.
wow. Okay, so keeping that LDL out of the artery wall is literally a matter of life and death. Now, why do some people have this transport problem? Is it all just lifestyle? Is it just the cheeseburgers?
Definitely not. The text classifies dyslipidemia into two main buckets, primary and secondary.
Primary being.
Primary is genetic, it's in your code.
The source listed 6 categories, which was a bit confusing, but it highlighted something called familial hypercholesterolemia.
Yes, this is a classic example of a primary defect. In these patients, their body literally cannot bind the LDL to the receptor.
The receptor is like the loading dock.
Yes, the liver uses LDL receptors to pull LDL out of the blood to recycle it. If you have familial hypercholesterolemia, you might lack those receptors or they might be broken.
So the LDL just keeps circling.
It just keeps circling in the blood, building up, eventually crashing into the artery walls. No amount of salad is going to fix a missing receptor. These patients often have exceedingly high cholesterol levels from a very young age.
That makes sense. But then there are secondary causes, and this was a huge aha moment for me in the reading. There are a ton of other drugs that can cause your cholesterol to spike.
It is something we often overlook. We call it drug-induced dyslipidemia.
Yeah.
If you were taking progestins, thiazide diuretics for blood pressure, glucocorticoids, beta blockers,
Even beta blockers?
even beta blockers, or isotretinoin for acne. All of these can skew your lipid profile.
That is wild. You could be taking a beta blocker to protect your heart, and it might be messing with your lipids.
It is a balance. Usually, the benefit of the beta blocker outweighs the lipid risk, but it explains why your doctor needs to look at your whole medication list.
It's not just what you eat.
It's about what else is circulating in your system.
The text also mentions physical signs. We said it's usually silent, but in severe cases, you can actually see it.
In severe genetic cases, yes. You might see xanthomas,
Which are?
fatty deposits right under the skin. You might see them on tendons, like the Achilles tendon, or even on the eyelids. It is literally the cholesterol having nowhere else to go, so it starts depositing in the skin.
Okay, let's move to the math.
Yeah.
The source material references the ATP3 guidelines for diagnosis. If I am a listener, when do I need to start worrying about this?
The guidelines are pretty clear. Screening should start at age 20.
20. I was eating pizza at 2 a.m. at age 20. I was not thinking about lipids.
Oh. And that is exactly why they check. You should get a fasting lipoprotein profile at least once every 5 years, starting at age 20.
And it has to be fasting. 12 hours.
Yeah.
Why is that? I know getting blood drawn when you are hungry is the worst.
It is, but it's crucial because of the triglycerides. When you eat, your triglyceride levels spike as your body processes the energy from the food.
Okay.
Total cholesterol isn't affected much by food, but triglycerides swing wildly. So to get an accurate baseline, you need that 12-hour window where the system is at rest.
Now here's a behind-the-scenes detail I found fascinating. When I get my lab results back and it says LDL 130, they didn't actually measure the LDL, did they?
Usually, no. It is too expensive and technically difficult to measure LDL directly in routine labs.
So what do?
They calculate it using the Friedewald formula.
Let's unpack the math here because it explains why the triglycerides matter so much.
Right. The formula is LDL equals total cholesterol minus HDL minus VLDL.
VLDL.
Very low-density lipoprotein. But here's a trick: standard labs don't measure VLDL either. They estimate it.
How?
They assume VLDL is equal to your triglycerides divided by 5.
So if my triglycerides are high, that estimation gets messed up.
Exactly. That divide by 5 rule only works if your triglycerides are under 400. If they are higher than that, the math breaks down and you cannot calculate LDL accurately. You'd need a direct measurement test.
It is amazing how much estimation is involved in something that feels so precise.
Yeah.
The text also suggests you shouldn't trust just one test.
No, absolutely not. Lipid levels fluctuate. Stress, minor illness, even your posture can affect it slightly.
Oh,
yeah. The recommendation is 2 tests, 1 to 8 weeks apart. If the numbers are wildly different, more than 30 points apart, you take a third and average them. You never want to start a lifelong medication based on 1 tube of blood taken on a weird Tuesday.
That's good advice. So we have our numbers. Now we have to figure out what they mean. The source emphasizes that treatment isn't one size fits all. It depends on risk stratification.
This is the most critical part of the guidelines. You treat the risk, not just the number. An LDL of 130 might be fine for a healthy 25-year-old, but dangerous for someone with other issues.
See, there are categories.
There are. The highest risk category includes people who already have coronary heart disease.
Which makes sense. If you have had a heart attack, you are high risk.
But here's the big insight. CHD risk equivalence.
What's that?
These are conditions that carry the same risk of a future event, greater than 20% in 10 years, as actually having heart disease.
And the biggest one is?
Diabetes mellitus.
This blew my mind.
Yeah.
If you have diabetes, the guidelines say we should treat you as if you already have heart disease.
Correct. The metabolic damage from diabetes is so correlated with vascular damage that we don't wait. We treat aggressively. In the eyes of the lipid guidelines, a diabetic patient essentially has the same risk profile as a patient who has survived a heart attack.
That's a huge deal. What are the other major risk factors on the checklist?
Age is the big one. Men over 45, women over 55. Family history of premature heart disease in first-degree relatives. Cigarette smoking, that's a huge one.
Of course.
Hypertension, so blood pressure over 1490 or being on meds for it. And low HDL, that under 40 number we mentioned.
But there's a bonus point available.
Yes. The only negative risk factor, if your HDL is really high, 60 or above, it actually counts as a negative risk factor. It subtracts 1 risk from your total count.
So it's protective.
It is. So if you are a 50-year-old smoker but you have super high HDL, the math changes slightly.
Slightly. But don't use that as an excuse to keep smoking.
Please don't. The smoke is still damaging the endothelium, inviting the LDL in.
Fair enough. So let's say the risk assessment says we need to do something. The source material outlines non-pharmacologic therapy first. We call this TLC.
Therapeutic lifestyle changes. This is the first line of defense, and I want to emphasize this. The source suggests that if you strictly follow all the dietary changes, you can reduce LDL by 20% to 30%.
20 to 30%. That's as much as some drugs.
It absolutely rivals the effect of some drugs.
That is huge. So what exactly are we eating? It isn't just eat less.
No, it is specific. First, reduce saturated fat to less than 7% of calories. That is tough. That means cutting way back on red meat, full-fat dairy, butter. But then you need to add things, specifically soluble fiber.
Like an oatmeal.
Oat bran, pectin, psyllium, yes. The mechanism is fascinating. Soluble fiber acts like a sponge in your gut. It binds to bile acids.
And bile acids are made from?
Cholesterol. The liver makes them using cholesterol. If the fiber binds them, you excrete them, you poop them out, instead of reabsorbing them.
So the body loses bile.
Yes, and the liver realizes it is running low, so it pulls cholesterol out of the blood to make more bile acids. Eating oatmeal literally forces your liver to clean your blood to restock its bile supply.
That is incredible. What about plant sterols? I see these in special margarines.
These are chemical lookalikes of cholesterol found in plants. They compete with real cholesterol for absorption in the gut.
So they block it.
Imagine a game of musical chairs for absorption sites. If the plant sterol gets in the seat, the real cholesterol gets kicked out. 2 to 3 grams a day can reduce LDL by another 6 to 15%.
And fish oil. Everyone takes fish oil.
Fish oil is tricky. It is great for lowering triglycerides and VLDL, but the source notes it might actually raise LDL slightly in some people.
Oh, really?
Yeah, so it is specific for certain profiles, mostly those with very high triglycerides.
Okay, so you've eaten your oatmeal, you have used the special margarine, you have lost the recommended 10% of body weight, which helps everything, but the numbers are still high.
Right.
Now we open the medicine cabinet.
Now we get to the pharmacologic arsenal.
And the undisputed king of this arsenal is the statin.
HMG-CoA reductase inhibitors?
Let's just stick with statins.
Good idea. Atorvastatin, simvastatin, rosuvastatin, these are the gold standard. They can lower LDL by 30% or more.
How do they work? Is it just scrubbing the blood?
No, it is much more elegant. They inhibit an enzyme in the liver HMG-CoA reductase, which is the rate-limiting step in cholesterol synthesis.
So they shut down the factory.
They shut down the factory line that produces cholesterol inside the liver.
And how does that lower the blood levels?
Because the liver still needs cholesterol to function, since it can't make its own anymore, it panics. It builds more LDL receptors, those loading docks we talked about.
Ah, okay.
It starts aggressively pulling LDL out of the bloodstream to meet its needs.
That is brilliant. It tricks the liver into cleaning the blood.
Exactly. It upregulates the receptors. But there's no free lunch. Side effects can include elevated liver enzymes and myopathy muscle pain.
And in rare cases, something more serious.
In rare cases, rhabdomyolysis, which is severe muscle breakdown that can damage the kidneys. But generally, they are very well tolerated.
Next on the list, we have the old school option. Bile acid resins or BIARs.
These work on the exact same principle as the oatmeal, just chemically supercharged. They bind bile acids in the intestine, so you excrete them, again, forcing the liver to use up cholesterol stores to make more bile.
But the user experience, the text describes it as gritty.
Yeah, it is a powder you mix with liquid, like sand. Patients often complain about the texture and the GI issues, bloating, gas, constipation.
That doesn't sound fun.
And you have to be careful. They can block the absorption of other drugs and vitamins. If you are taking warfarin or vitamins A, D, E, K, you have to space your dosing by several hours.
And the source mentioned a specific warning. Don't use them if triglycerides are high.
Right. For some reason, when the liver is forced to make more bile, it sometimes ramps up VLDL production too. So if a patient already has high triglycerides, BARs can make that worse.
Okay, number 3, niacin, nicotinic acid.
This is an interesting one. It reduces the production of VLDL in the liver. But its superpower is that it also increases HDL, the good cholesterol, by reducing its breakdown. It is one of the best agents for raising HDL.
But there is a catch, the niacin flush.
Oh, it is famous. Because of prostaglandins, it causes cutaneous flushing and itching. Your face can turn beet red and burn. It can be quite alarming if you aren't expecting it.
Can you do anything to prevent it?
The text suggests taking 325 milligrams of aspirin shortly before the dose. Also, take it with meals, do not take it on an empty stomach, and crucially, avoid hot drinks or alcohol at the same time.
So no niacin with my morning coffee.
That would be a very, very red face.
Good to know. And it has some risks for diabetics.
Yes, it can cause hyperglycemia, high blood sugar, and also gout by raising uric acid, so you have to be careful in those populations.
Let's talk about fibric acids or fibrates. Gymfibrocell, fenofibrate.
These are the specialists for triglycerides. They increase the clearance of triglyceride-rich lipoproteins. If your main problem is TGs and VLDL, this is often the go-to drug.
But watch out if you were on warfarin.
Huge warning flag. Fibrates potentiate the effects of warfarin. That means they make the blood thinner. If you don't adjust the warfarin dose, you risk bleeding.
So close monitoring is needed.
Very close. They also carry a risk of gallstones and muscle inflammation, especially if the kidneys aren't working at 100%.
Then we have ezetimibe. This seems like the sidekick drug.
It is a great add-on. It works at the brush border of the intestine to block cholesterol absorption. It doesn't inhibit production like a statin. It just stops you from absorbing what you eat or what is recycled.
And the numbers. How effective is it?
Alone, it lowers LDL about 18%. But if you add it to a statin, you get another 12 to 20% drop. It is well tolerated, which makes it very useful for combination therapy when a statin alone isn't enough.
Finally, fish oil again. But this time as a prescription.
Yes, prescription strength, like Lovasa, we are talking 4 grams a day. That is a lot of capsules.
What's it for?
It lowers triglycerides significantly, up to 30%. But at that high dose, you have to watch for bleeding disorders or thrombocytopenia low platelets.
So that is the arsenal. Now let's look at how these are applied in specific scenarios. We mentioned diabetes earlier. The text calls it diabetic dyslipidemia. It has a specific signature, doesn't it?
It does. It is usually high triglycerides, low HDL, and this is crucial, small, dense LDL.
Pattern B.
Right. Think of normal LDL as big, fluffy beach balls. They bounce off the artery wall. Diabetic LDL pattern B is like BB pellets.
Small and dense.
Exactly. They penetrate the wall much easier and are more likely to oxidize. They are much more atherogenic, meaning plaque-causing.
So even if the number of LDL looks okay, the type of LDL is more dangerous.
That is exactly right. Which is why the primary target for diabetics is still lowering LDL aggressively, usually with statins, even if the total number doesn't look astronomical. The quality of the particle matters.
What about when triglycerides are off the charts? We talked about heart attack risk, but very high TGs have a different, more immediate risk.
Pancreatitis.
Yep.
Yes. If triglycerides get above 500 mg/dL, the risk isn't just long-term heart disease. It is acute inflammation of the pancreas, which is incredibly painful and dangerous.
So the strategy shifts.
Completely. If TGs are that high, we stop worrying about LDL for a moment and focus on getting TGs down immediately. Fat restriction in the diet, very strict, 10-20% of calories. No alcohol whatsoever.
What about drugs?
Drugs like fibrates, niacin, or high-potency statins, whatever it takes to get those TGs down below 500.
And sometimes one drug isn't enough. The source talks about combination therapy.
It is logical. If a statin stops the liver from making cholesterol and a BAR stops the liver from recycling bile, using them together hits the system from 2 angles. It's a 1-2 punch.
Or statin plus ezetimibe.
Right. Block synthesis plus block absorption. It makes perfect sense.
But we have to be careful combining things.
Yes. The text explicitly warns about statin plus fibrates or niacin. Both classes can cause muscle toxicity, myositis. Combining them increases that risk. You have to monitor the patient very, very closely for muscle pain.
Speaking of monitoring, once we start these treatments, what is the timeline? You don't just send them off for a year.
No, absolutely not. You check a lipid panel 4 to 8 weeks after starting a drug or changing a dose. You need to see if it is working and if the liver is handling it.
And the liver function tests are mandatory for statins and niacin.
Baseline and periodic checks. We need to make sure we aren't damaging the very organ we are trying to manipulate. Once they're stable, you can check every 6 to 12 months.
And there is a note here about dietary adherence, using diet diaries.
Yes, because memory is fallible. Patients often think they're following the TLC diet, but a diary keeps them honest.
And keeps them accountable.
Exactly. It is hard to hide that extra slice of pizza when you have to write it down. It keeps the patient aware of what they are actually consuming.
So we have unpacked a lot here. From the microscopic invasion of the artery wall to the math of risk factors to this whole toolbox of treatments.
It is a comprehensive picture, and I think it reinforces why dyslipidemia is the better term. It is a systemic dysfunction, not just a high score on a test. It is a complex interaction between genetics, diet, and metabolism.
It really emphasizes the value of knowing your numbers, your LDL, your HDL, your triglycerides, because the symptoms are so often silent until it's just too late.
You can't feel your LDL oxidizing.
No.
You can't feel the foam cells forming. Knowledge is the only way to intercept that process before the plaque ruptures.
That leads me to a final thought I wanted to bounce off you. We spent a lot of time on drug statins, fibrates, resins, and they are powerful tools that alter our biochemistry.
They are.
But looking at the stats in the source, dietary changes alone can yield a 20 to 30% reduction in LDL. That rivals the effect of a starting dose of a statin.
It is a provocative thought, isn't it? We often look at these conditions as inevitable or purely genetic, but the source suggests that the foundational prescription remains what we put in our bodies: the fiber, the sterols, the fats.
So lifestyle isn't just good advice.
It's potent medicine in its own right. The source really invites you to reflect on the power of those therapeutic lifestyle changes, not as an alternative to medicine, but as medicine itself.
We have more control over the transport system than we think.
We do. And that is a good place to start.
Well, thanks for taking this deep dive with us. Go check your numbers, maybe eat some oatmeal, and we will catch you next time.